I think we're live. Yep, looks like we're live. All right, great. So just started up the stream. We'll see if anybody comes in. I'll leave this rhythm up until then, but in the meantime, we're just going to be doing EKG, ACLS, anything EMT, paramedic, pre-hospital, critical care, flight, transport medicine, emergency, acute stabilization of unstable patients. We'll focus on what students are mostly going over, ACLS level, that kind of stuff, but we often get into the weeds. So we'll see if we get any viewers. In the meantime, well, there's nobody in here yet, as far as I know. I'm just getting the hang of this streaming thing from the laptop. I usually do this from my phone. This is the second stream we've done. And it's weird because I know this is going to go up as a recording on my page, but I feel weird just diving in while nobody's here. So I apologize if anybody's watching the replay, but I feel like it'd be wasted to jump in. I'll give it a minute. It's only been up for a minute. So if you want to skip ahead, I will go through this rhythm at 3 minutes. We're going to give it a minute and a half, see if anybody comes in. Then we'll break down this rhythm at the 3-minute mark. I can see the chat, so if anybody does come in, hopefully there will be some interaction. Ideally, there's some people who will answer and attempt to interpret the rhythm, and then we'll kind of talk about it from there. But at the 3-minute mark, if you want to skip till there, I will start breaking down this rhythm. Until then, I'm going to sit here and talk to myself, apparently, and so it won't be super interesting. Wow, we had 3 viewers on Twitch. Crazy. Oh, I should have gone for 3 more minutes. Now live on YouTube, so it sent out an alert, so maybe somebody will come in. At the 3-minute mark, we'll dive in so that when this does go up on my page, it's not a waste. I'm not sure if I can edit it. I'm going to check that if you're allowed to edit your live streams. I doubt it, but we'll see. All right. So nobody yet, but for the sake of the replay, we'll dive in. All right, there's the 3-minute mark. So if you skipped ahead to see, nobody did come in yet, but we'll just start breaking some rhythms down and we'll go through some different things and then we'll see if anybody comes in while we're doing it. So we got a tachycardia. We're always going to go through our structured approach, especially in class. That's very important. I know you're going to see people out there who just jump in and they see a rhythm and right away they have an interpretation of it because they've seen certain things thousands of times, hundreds of times. And in class, you'll miss some really easy ones doing that. They'll give you a rhythm that has a rate of like 99 beats per minute. And you'll look at it and you'll go, oh, that's a sinus tachycardia because it looks very fast. And it'll actually be a normal sinus rhythm because it was 1 beat off. So especially in class, go through your structured approach. Now our monitor is giving us a rhythm around rate around 200. It's jumping around a bit because we have these PVCs that are popping into our rhythm. It's not perfectly regular. When a rhythm is irregular, your monitor is going to jump around a bit and not be exactly accurate because depending on the number of PVCs and what's going on, if the rhythm's irregular, it's not going to be the same every minute. So it is actually changing, and your monitor's doing its best to keep up. The more irregular a rhythm gets, the more ectopy a rhythm has, the less accurate your monitor's calculation of the rate is going to be. Your monitor takes 3 RR intervals. The distance between 2 of these tall R waves takes 3 of those, and it averages it out. And then it divides 60 seconds by that to figure out the rate. So every once in a while, it's getting these different averages measuring RR intervals. And that's how your actual monitor, your real life, your LifePak 15, your Zols, that's how they're doing that. And that's why it bounces around like this. So here, we have a rate around 200. We have a very regular rhythm other than these intervening wide complexes. And we'll get to those later. Those are PVCs. But we can basically ignore it now. We need to figure out our base rhythm. And then whatever it is, we'll just mention that there are polymorphic shapes of PVCs. We'll talk about that when we get there. We have a very regular rhythm. So structured approach, we do our rate, then we do our rhythm. Structured approach here, extremely regular outside the PVCs. Then we go looking for waves. That's tough in this one. Gosh, are there any P waves? Doesn't look like it. It's hard to tell. Not going to have a definitive answer on that one. So next we're going to look at the QRS. It's narrow. We don't know if there are P waves, so we aren't able to look at a PR interval, things like that. That's probably the beginning of like a T wave, and then it just gets interrupted. There's definitely some variation in between these, so we might be thinking, I wonder if there's underlying atrial fibrillation with a rapid ventricular response. That's certainly a fair thought to have. But we have an extremely regular rhythm. Even at fast rates, there should be some irregularity, but it does get extremely subtle at fast rates. So we don't know. This is going to be a supraventricular tachycardia because of that. The term supraventricular tachycardia, in clinical use, you're literally saying to someone, when you give that in a turnover report, you're saying, look, there's not enough information to say the specific mechanism underlying this narrow complex tachycardia. We can't see if there's P waves, if there's inverted P waves, if there's fibrillation waves, if there's flutter waves. We just can't see. And so we default to the generic category of narrow complex tachycardia, supraventricular tachycardia. There is an underlying rhythm here. That's what they're talking about when they teach you about adenosine. We'll get to treatment in a few minutes, but that's what they're talking about. When they say adenosine may reveal the underlying rhythm, they're saying to you, there's an underlying rhythm here and we can't figure it out. There's not enough information on this EKG tracing to get to a specific interpretation. So we're just going to name the category of what's going on, which in this case is narrow complex tachycardia, SVT, supraventricular tachycardia. So our first question is that is going to be, is it stable? If this patient is stable, then we're thinking about doing a Valsalva maneuver, a vagal maneuver. The modified Valsalva is a good one to do. I like the modified Valsalva. That's where you sit them up, full Fowler's position, have them do the vagal, so blow into a syringe, trying to blow the end out, blow into a straw, bear down, whatever it is. You have them do that, and then you lay them flat while they're doing it, and you lift their legs up to a 90-degree angle, and that has great conversion. I think the data says like a third. I've had great luck with it. I feel like half my patients that I do it to respond. Not that you're doing it all the time, a couple of times a year. It's not super common. Then after that, we're going to be looking at drug therapy. So we're going to think about adenosine, cardizem in the emergency room and in the pre-hospital environment. Those are kind of the go-to these days. It used to be you always did adenosine first, but cardizem has proven to be equally as effective. So you can kind of choose now. They're both frontline treatments for supraventricular tachycardia. Adenosine works quicker, but has more side effects. It bottoms out that blood pressure. It stops the heart. It causes sinus pause a lot of the time. Not always, but a lot of the time. And patients hate that. It makes them feel really bad. They have chest pressure. They have shortness of breath. They feel like they're dying. Their heart literally stops some of the time. Sometimes it doesn't. Sometimes the rate just slows down. Sometimes it just converts. Sometimes you get 15 seconds of a sinus pause, 20 seconds, which is a long time to have your heart stop. So some patients despise adenosine, and cardizem's a better choice. Depends on how symptomatic they are, what's going on. Cardizem doesn't have the side effects. It's not going to do that, and it can convert this with equal efficacy, but it takes 10-15 minutes. It's not as rapid as adenosine. It's a good choice, though, and they're equal. So if you have cardizem available to you in your protocol, you may be able to choose between adenosine and cardizem. Then there are other options outside of ACLS. If you work in an ER, if you're a nursing student, if you're going to work in an ICU or are working in an ICU, then we have a different setup where they're not bound to ACLS. It's not protocol medicine. If you have a patient who has heart failure with a reduced ejection fraction, that's a whole other story. You're not going to give them a calcium channel blocker. Yeah, cardizem is cardio-specific. It's a non-dihydro whatever. There's dihydra, the different classes of calcium channel blockers. So it's not necessarily contraindicated or anything, but a lot of clinicians are just not comfortable giving a calcium channel blocker to somebody who's got an underlying possible shock state, to somebody with heart failure with reduced ejection fraction, things like that, somebody who's vasopressor dependent, like you'll see in the ICU. And so they're going to avoid cardizem. Maybe the patient's in a step-down unit post an open heart surgery. They just had a cabbage or something. You're not going to find a cardiologist on the planet who's going to want to slam adenosine into a 1 or 2 day out of open heart surgery patient's heart, stop it even for 10, 15 seconds. They're just not going to do that. What they generally reach for is amiodarone. So the medics and the nurses, the ACLS level stuff, we're going to look at that and think amiodarone, that's the wrong answer. It's adenosine. You mistook your medications that start with an A. But be careful about that because amio is a perfectly reasonable choice for a frontline medication in SVT. It's not in EMS's protocols. That's totally fair. The ERs usually don't reach for it, but if you work in an ICU, you're going to see amiodarone reached for as the frontline treatment for SVTs. It's great in patients who have heart failure with a reduced ejection fraction, or a few days out of some kind of open heart surgery, or not even open heart surgery, any heart procedure at all, where no cardiologist is going to want to slam adenosine into that patient. It's just not going to happen. So they'll reach for amiodarone, and there's a ton of data showing amiodarone is perfectly safe and effective. So EMS, ER, we're probably doing adenosine first. We may be doing cardizem first. ICU, critical care transport, you may be reaching for amiodarone for a supraventricular tachycardia. A beta blocker is not a bad choice either. The efficacy is lower than all those other things that we just talked about, so they're generally considered third line. So usually if adenosine in EMS, let's say, or the ER, if adenosine didn't work, okay, then maybe you'll try cardizem. If cardizem didn't work, maybe you'll try amiodarone. If none of those worked, usually it's the third line thing that you reach for is to go for a beta blocker in supraventricular tachycardia, undifferentiated supraventricular tachycardia. Totally reasonable as well. And in EMS, of course, we're always saying things like unstable gets the cable. In a facility, if you work in an ER, if you work in an ICU, elective cardioversion of a stable patient is absolutely routine, safe, and effective. Now, they're going to get procedural sedation. They're going to get, in EMS, we would use a benzo or ketamine. In the ER ICU, they may still get ketamine. That's an excellent choice. They may get etomidate. They may get propofol. There's a wide range of changes, but there's going to be a full-on procedural sedation, which facilities take very seriously. They're going to have RT there. They're going to have a couple of ER nurses. They're going to have an ER doctor there. And then they're going to procedurally sedate and electively cardiovert a stable supraventricular tachycardia. So that's a totally reasonable option too that EMS is probably not going to do. The whole saying unstable gets the cable doesn't mean stable patients never get electrically cardioverted. It means we're not going to do that in an uncontrolled environment, in a patient's living room, in a movie theater, in a restaurant. That's something they're going to do in a facility where they have RT, where they have the ER doctor, where they have a couple of ER nurses. And if you've ever seen procedural sedation done in those settings, well, you know it's taken very seriously. In EMS, we go, oh, don't forget to sedate them if you're going to cardiovert and their blood pressure can take it. And we do it with one medic, and there's, an engine crew of 3 EMTs and your EMTA partner. But in the facility, all procedural sedation, whether it's for a cardioversion or anything else, is going to have an ER doctor, a couple of ER nurses, RT, the airway setup, all of that ready to go. It's taken very seriously, especially when it's elective, when it's of a stable patient. So don't be surprised when you see that, even though EMS does not do that. In EMS, it's unstable gets the cable. Unstable patients, we cardiovert. Stable patients, we're not going to do electrical cardioversion on, not because it's not reasonable, but because we don't do that in uncontrolled environments. We want the backup. We want the airway stuff already. We want to have the staff and hands around in case things go wrong. So all of those are totally reasonable things that you may see happen if you work in an ER, a facility, things like that. If you had a stable SVT and you work rurally in EMS, and you got an hour and a half transport out of the mountains of Colorado or something, you may get an online medical direction order to stably cardiovert. It wouldn't be unreasonable. Nobody's going to want to leave an SVT going for upwards of an hour, that kind of thing. So just know that that is a perfectly reasonable thing to do, a perfectly reasonable thing to consider in SVT. It's just not in our base protocol. It's not what ACLS talks about. But as we saw with ACLS updates this week, they're not the most comprehensive medicine around. There's a lot more to know than just ACLS. So we'll move on to another EKG. Oh, we lost our one viewer. I'll give it a moment in case anybody comes in, let them interpret it. In the meantime, we'll dive in. Heart rate is 76. No red flags there, a very regular rhythm. Then we go through our structured approach to look at waves. Well, we got P waves, a little lopsided to the left, but upright, uniform, identical throughout this tracing. So sinus originating. Doesn't look like there's anything wrong with the sinus node. Doesn't look like there's anything wrong with the atria. And then all of a sudden we have a sharp upward spike and a wide QRS with a strange looking T wave. That spike should always kick off, hey, a thought process. This is probably a pacemaker. That spike is what tells us that we have a pacemaker, an artificial pacemaker, which is exactly what's going on here. We have an artificial pacemaker going. Now, the mode that it's in, you can't know all the specifics about the mode, but we can say some generalities here. We have a native P wave. The sinus node's working. We have a well-formed shape to it. So we can say this is a sinus originating rhythm. And then we have that pacer spike. So the pacemaker is looking at that P wave and thinking, okay, we got atrial contraction. We need the ventricles to go off next. And it looks for the ventricles to go off. It looks for a narrow QRS. And then after a pre-programmed time, usually around 200 milliseconds, not much longer than a normal PR interval, the pacemaker goes, we didn't get a QRS. I got it. I'll take care of it. Sets off a pacer spike, which initiates a ventricular contraction. And that's our wide, bizarre-looking QRS. So we have an atrial-sensed, ventricularly paced rhythm here. This is for a patient who has no problem in the atria. Their SA node is perfectly healthy. The problem is AV synchrony. So maybe they had a third-degree heart block, something like that. And so now their pacemaker watches the atria and responds to what's happening. If they did happen to occasionally, maybe it's a type 2. Occasionally they do have second-degree type 2 AV block. Occasionally they do have QRS complexes. And the pacemaker is probably in a demand mode where it would notice that and allow the intrinsic function of the heart to happen if it happens normally, and it's only jumping in when there is not. To get all of the details of the programming of the pacemaker, we would need a pacemaker interrogation, which we don't have here. So all we can say is the active mode here is atrial sensed ventricularly paced. Atrial sensed ventricularly paced. I'm going to change the verbiage of that. We shouldn't really say ventricular pacemaker. It sounds like we're talking about the physical device, but really we're talking about what it's doing, the modality that it's in. So we have an atrial sensed, P-wave's got no problems here, ventricularly paced. We have a ventricular pacer spike and a wide QRS, which is expected. The ST elevation, you may notice there, is expected, but do everything you can in single lead rhythm interpretation to not pay attention to ST elevation. That's for 12 leads. If you see it, it may tell you to go get a 12 lead, but it's not telling you there's a heart attack. It's not telling you anything. In this case, it's expected. We get some ST elevation with paced complexes, with wide QRS complexes. That's just par for the course. Abnormal depolarization equals abnormal repolarization. And because we have a wide QRS, the T wave actually starts. I'll pause this. We'll flip over to paper. The T wave actually starts before the end of the QRS because the QRS has taken so darn long. The initial cells that depolarized are repolarizing before the end of the depolarization of the ventricles. And so the T wave actually starts over there, and this ST elevation is not unlike early repolarization. It gets meshed together, and we get an elevated ST, J point. It's nothing to worry about. That's expected. Now, it doesn't mean there's not an MI going on. We can evaluate this for MI. We just need to do it on a 12 lead, and we won't use our standard STEMI criteria. Those are out the door in wide QRS complex rhythms. Instead, we'll use what's called Scarbosa criteria. Specifically, the latest version is the Smith modified Scarbosa criteria. And that looks at the degree of ST elevation, the degree of reciprocal changes in ST depression, and whether it's in the same direction as the QRS, concordant changes, or a different direction, discordant changes. So it's a whole other set of criteria that'll let you spot a myocardial infarction in a rhythm that is a wide QRS complex like this, where the ventricles are being paced, artificial ventricular pacing. In this case, we have atrial sensing and ventricular pacing. Or in something like a left bundle branch block. Also a wide QRS complex. Can't use standard STEMI criteria. Some ST elevation is expected. And so we use the Smith modified Scarbosa criteria. And we'll get into those in another stream. All right, new rhythm. Yeah, it doesn't look like we have too many people in here. Oh, no, we had one. But this replay gets put up, so I'm just going to keep going. Hopefully more people will come in. If you're watching this on the replay, thank you. I appreciate it. Be sure to, you can use this software that we're generating these rhythms from. Be sure to check out the website. And I'm going to keep doing these streams, so keep an eye out, follow, bell, all that good stuff. And when I go live, you'll get notified. Once I have a little bit of a viewer base on YouTube, we'll start doing more advanced stuff and do like 12 lead interpretations, things like that, because I have a lot more freedom on here, unlike some of the live streams on a few of the other platforms, and we'll be able to show a whole 12 lead on screen, and we'll get into that kind of interpretation. So here we have a heart rate of 50, so the pulse is bradycardic here. Then we look and we have, well, it's kind of regular at some parts, and then it's not regular like a metronome. It's not a constant beat. The R waves have an RR interval that seems to be repeating itself, but then we have a large gap. And then that same RR interval, and then a large gap of the same size. This is called grouped beating or regular irregularity. This rhythm is not regular like a metronome. That's not what's going on, right? We have a big gap here, but it has a pattern to it. There is a regular pattern to this. Grouped beating of 3 R waves. Grouped beating of 3 R waves. So we have grouped beating or regular irregularity. Then we move down and we look at our waves. All right, we have upright, uniform, identical P waves throughout this rhythm. There's nothing going on with the P waves. The PP intervals are all identical. The P waves all look identical. They are upright. They are uniform in lead 2. That gives us a sinus origin. There's a sinus origin here. This is a sinus rhythm, in fact. But there's something else going on. We notice we have a P wave. Every fourth P wave doesn't have a QRS complex. So that should tip us off to the fact that we're dealing with a second-degree AV block of some type. So then we think, well, there's 2 types of second-degree AV blocks. There's Winky block, second-degree type 1, and there's Mobitz 2, second-degree type 2, also known as Hay block. Dr. Hay gets none of the credit. He also described these. Also sometimes called Hay block, especially in older textbooks. So how do we spot a Winky block? Well, we take a cycle, and we look for that lengthening PR interval, the longer drop. Then you've got a Winky block pattern. But when we come in here, there's no changes to the PR intervals inside of a cycle. They're all the same. The PR interval is not lengthening leading up to our missing complex. So right there we can say, well, if it's not Winky block, it's got to be second degree type 2. It's got to be a Mobitz 2 second degree AV block. And that's exactly what we have here. Now, this is a fixed ratio block. These can be intermittent with randomly dropped QRS complexes too. So the ratio here that we report in AV blocks is the number of P waves to the number of QRS complexes per cycle. And here we have 4 P waves to 3 QRS complexes per cycle. So this is a 4-to-3 ratio, AV ratio, P to QRS ratio. The P waves are the A, the atria. The QRS complexes are the V, the ventricles. So the AV ratio here is 4-to-3. So this is a second degree. We have P waves without QRS complexes. Mobitz 2, type 2. The PR intervals in each cycle are fixed. There's no lengthening. There's no changes at all inside the cycle. So we have a Mobitz 2, a second degree type 2, aka Hay block, Hay, with a 4-to-3 ratio. Second degree type 2 fixed ratio atrioventricular block. That's what we got here. We just did this one. The EKGs come up randomly, so sometimes it'll like do that. Oh, this is a rough one. This is a rough one. Heart rate's 25, and that's a stretch. Looks more like it's between 10 and 20. It is regular. I'm not seeing a difference in the spacing of either the P waves or the QRS complexes. We do have P waves, rate of about 50 a minute. There's 5 of them inside a 6-second strip here. So this is a 6-second strip. So if we pause it about there, 1, 2, 3, 4, 5, almost 6. So we have a rate, high 50s. But our ventricular rate, boy, that's not great. There is a repeating pattern here. Every 1, 2, 3, 4, 5, every 6th P wave, is successfully conducting into a QRS complex. So we have P waves without QRS complexes, absolutely. We should be thinking second degree AV block. But when we go down and we try to think, well, is this a type 1 or a type 2? How do I figure that out? Remember that we can't compare the first PR interval in 2 cycles. Whether it's Winky-Bach or Mobitz too, that PR interval is expected to be the same in the first complex of a Winky-Bach cycle or a fixed ratio second degree type 2, Mobitz 2. In Mobitz, it never changes. But in Winky-Bach, the first complex in every cycle, that's where our PR interval resets. So that's exactly what we expect here. In order to use our rules of longer drop or fixed PR intervals, we've got to be looking inside a cycle. We need consecutively conducted P waves, which we don't have here. So this is a special category. When you see an AV ratio of 3:1 or greater, here we have 6:1, or was it 5? 1, 2, 3, 4, 5, 6:1. The ratio here is 6:1. That's known as a high-grade atrioventricular block. Some textbooks will call it an advanced second-degree high-grade or second-degree advanced AV block. And like a 2:1, that also falls in the category of untypable but isn't considered high-grade. Without consecutively conducted P waves, we cannot determine the type. Both pathophysiologies of Winky-Bach conduction, increased refractoriness of the AV node, and Mobitz 2, structural damage of the AV node, resulting in sudden catastrophic failure to conduct, can result in these patterns of high-grade AV block. Now, the longer the ratio, the more likely you're dealing with Mobitz 2, but there's no way to say for sure. We can't say for sure. So this is an untypable. It has its own special category known as second-degree high-grade or advanced AV block. Untypable. We can't determine the underlying patho. Remember, Mobitz and Winky-Bach are not, excuse me, Mobitz and Winky-Bach, I'm going to cough again. Hold on, let me mute the mic. Excuse me. Mobitz and Winky-Bach are not patterns on the EKG. They're pathologies of the AV node that create prototypical patterns. But sometimes we can't differentiate based just on the pattern what the underlying pathophysiology is. High-grade AV blocks are one of those times. It could be either. So we're going to assume it's catastrophic. We're going to assume it's the second degree type 2, the Mobitz 2, no atropine, and we just need to pace this patient. The odds of them being asymptomatic or unstable with a heart rate of 25, 1,000,000 to 1, 1,000,000 to 1. We're going to go ahead and pace this patient. Their heart rate's 25. That's our intervention. That's what we're going to do. The problem is the rate. Let's fix the rate. This is just a narrow complex bradycardia at the end of the day, with the special caveat that unlike some narrow complex bradycardias like sinus bradycardia, we're not going to give it atropine. So let's just jump in and pace this patient. That's going to be our best front line intervention. Doesn't mean it's going to stabilize them perfectly. We may need to look to pressors. We may need to look to inotropes, things like that. But the first step is get rate control. Get that rate up to something reasonable, reevaluate their blood pressure. All right, classic ACLS rhythm here. Absolutely classic ACLS rhythm. Everyone's going to need to know this. We have asystole. Asystole. Nothing going on. A lack of systole, right? Your systolic blood pressure, the systolic period of the cardiac cycle, we have no beating. There's nothing going on here. Nothing's happening. There's no electrical activity, meaningful electrical activity. You're never going to see a perfectly flat line. Maybe if you turn the gain like all the way down on your monitor during asystole, it'll be pretty darn flat. But even when you run on patients that are DOA and have been for quite a while, but they don't have obvious signs of death. Maybe rigor has passed, it's been a few hours, and there's no dependent lividity, things like that. You put an EKG on a biological system, even one that's been DOA for a while, you're going to see something like this. This is not fine VFib. There are very low amplitude VFibs. So you can have what's called occult VFib. That it is a thing. Where in one lead you don't have anything. That's why you have to collect 2 leads. Generally, you don't have that in all leads. So lead 2 might not show much of anything. Then you switch over and look at AVR or lead 3 or one of the other leads, V1, and you notice, oh no, this is actually VFib. But it's not because you can't see it. It's because you need to go find it in another lead. And occasionally it is very low amplitude in any lead. That's fair. But we don't have any criteria to differentiate that. So fine VFib is just not a term that's ready for clinical use. Until they can say, and people are working on this, but there's not a lot of data. There's like a dozen papers on that mention something like fine VFib or the amplitude or duration of component waves of ventricular fibrillation since like the 1980s. So, while it is something we should think about, and some people lately have been arguing that we should be shocking asystole on the off chance that there is something here, that's fine with me. But the term fine VFib is really messing with students. And until we can say the difference between coarse and fine VFib is component waves that have an amplitude of X and duration of Y, and say above that it's coarse, below that it's fine, that kind of thing, we need to just teach students the classic paradigm. It was already confusing enough because there's also no verified, validated, published metrics between VFib period and asystole. And so the problem is students are taking ACLS, they're doing their cardiac portions of medic school and nursing school, and they won't call anything asystole. If you see this in ACLS, you need to be running an asystole PEA code, not a VFib code. And students are not confident calling anything asystole anymore because everything's being called fine VFib by some people, and we can't define what that is. When a student asks the instructor, well, what is fine VFib? The instructor goes, you know it when you see it. Yeah, it's small. And until we have a validated, data-driven clinical answer for what the definition of those things are, they don't belong in the field. They don't belong at the bedside. They belong in research where they're working on defining what those terms mean. And so this is asystole. If you see this in ACLS class, don't go, oh, it's fine VFib, I'm going to shock it. Don't do that. Run your PEA asystole code. We don't shock asystole. Defibrillations provide for the opportunity for electrical activity to reorganize itself. They do not impart electrical activity onto rhythms that have none. Tracings, I should say, there's no rhythm here. Tracings that have none. There's no electrical activity here to reorganize. So shock isn't going to do anything for this. We spent a long time shocking asystole. That used to be, we tried to pace asystole too. We're just going back to the 70s and the 80s now. So if you want to shock this, go ahead. If your medical director will allow you, you're not going to hurt it. But let's not call it fine VFib and convince everybody that everything is secret, super small, fine ventricular fibrillation. Let's just say we're shocking asystole on the off chance that it is an occult ventricular fibrillation, on the off chance that the lead or two I looked at don't have amplitude, but one of the leads I didn't look at do, that kind of thing. Just say we're shocking asystole. No problems with that. No problems with that. You can't hurt it. Why not? But let's hold off on these terms that are subjective, that the only definition you can give of what's the difference between coarse and fine VFib. Well, the difference between coarse and fine VFib is you know it when you see it. Opinion, provider judgment. One or two papers out there have attempted to define it. I shouldn't even say attempted. The papers had nothing to do with defining it, but to write the paper, they used retrospective data on VFib and asystole, and in order to do the research, they needed a cutoff. And so they got it when you read the methodology by asking 3 ER doctors. They came up with 1 to 3 millimeters of amplitude would be fine. Above that would be coarse. Below that would be asystole. Not data driven. Doesn't mean anything as far as when we talk about the coarser it is, the more successful defibrillation it may be. There is data out there to support that concept, but not based on the amplitude or duration of waves in a single lead or even a surface EKG. Some of it's theoretical, where they built models of points on a cylinder. Some of it's in dog hearts, but they used mesh electrodes, and then they put the data through complicated statistical mathematical models to define what organization, the level of organization was. It wasn't, oh, I'm looking at a single lead, I think those look big, I think those look small. Eventually we'll get there. There's going to be some cutoffs inside of that. I fully believe that. It's just not ready yet, as evidenced by the fact that when a student asks an instructor, what's the difference between coarse and fine VFib? The only thing an instructor can say is, you know it when you see it. Coarse is big, fine is small. But the cutoffs just aren't there. So this is asystole, not fine ventricular fibrillation. If you are an experienced provider, If your medical director will allow you and you want to shock asystole on, save the 1 in a million case where it's occult VFib. Actually, occult VFib can be more common than that. That's fair. But let's just say what it is. We're shocking asystole. Great. Let's do that. I have zero, I wouldn't get in an argument over that. I have no qualms with that. My qualm is all about the verbiage. And defending doing that by calling it fine VFib is confusing the heck out of students. And the term fine VFib or coarse VFib is not ready for the bedside. It's not ready for clinical application. It has nothing to back it up. No defined standards. No way to teach a student what is or is not one of those things. And until we're at a point where we can do that, the terms aren't ready for clinical use. And we are confusing students, and they are trying to run what need to be PEA asystole codes as fine VFib codes and failing in class. They are getting this question on an EKG tracing, an EKG rhythm interpretation test, and they're answering VFib to this question, this rhythm, what we have on screen now. And this is asystole. And so we need to go back to teaching students that asystole exists. It is a thing. We can't just call everything fine VFib so that we're hiding the fact that we want to shock asystole. Again, no problem shocking asystole. My problem is using made-up subjective terms in order to defend doing it in a way that is really confusing a lot of new people and students. So you want to shock it? Fair. I have no argument against that. You're not going to hurt this patient. Go ahead and shock it. But just admit that we're shocking asystole. So I think that's about it. We're going to wrap the stream up. Been almost 40 minutes. Yeah, looks like we had one viewer. Thank you, viewer. I appreciate you coming in here. Maybe some people will watch this on replay, but I'm going to keep doing these. Hopefully they'll take off a little bit and more people will watch. We'll keep doing live streams. And yeah, you can play with this EKG generator. Check out dialedmedics.com. I'm not being paid to shill other people's stuff. This is my software EKG generator. I wrote it. I coded it. I've been using it to teach EMS, nurses, continuing education, ACLS, all those classes for a very long time. Well, the EKG generator only a few years when I wrote it. The teaching those classes for a very long time. I think it's helpful. So if that would help you out, if you want to get in some practice doing these ACLS rhythms, there is a free version that covers most of that. And then there's a paid version. We're using the pro version here. If you support what I'm doing, you can throw me a couple of dollars and you get a much expanded list of rhythms, including crazy stuff like multifocal atrial tachycardias, wandering atrial pacemakers, the special cases of second-degree blocks, 2-to-1 and high grade. You get ventricular standstills. So the free version gets just kind of a way to practice your ACLS algorithms. So check that out if it would be useful to you. It's out there for everybody, dialedmedics.com. And I'll see you guys next time. Thank you so much for people who are watching in the future, the replay.